Hi, we start the session Boehringer Symposium, where it's my real pleasure to introduce my dear friend Majdi Idris. Majdi Idris, احنا we're abusing you. We're abusing you. The Broncologist Society is abusing you. But what can we say? الجمعية بتحبك يا مجدي، هنعمل ايه بس؟ Professor Majdi Idris مش محتاج طبعا. He's one of the major pillars من guest faculties بتوع bronchology. Like I have to say برضو ان he's the head of respiratory medicine department at Riyadh Force Hospital, head of Saudi advisory group of pulmonary hypertension, ISAF, King Saudi Arabia. Where it's a real advantage if you have the facility to attend one of his meetings. He's a real pioneer or a specialist in the field of pulmonary hypertension. But he's going to discuss with us the Boehringer issue, which is a new hope for the uncontrolled asthma patients. The floor is yours, ya Makti.
Assalamu alaikum wa rahmatullah. Again, thank you very much for this awesome introduction. You all know that Professor Safwat always like to basically describe the situation, and that reflects his genuine nice personality more than anything else. So you may not believe everything he said about me. So we're going to talk about bronchial asthma, different from the pulmonary hypertension, and whether we have a new tool now in controlling asthmatic. This is my disclosure. As you know, this lecture is sponsored by Boehringer, and I do work with many companies giving talks and receiving research grants. So let's discuss the journey for asthma, our journey as respirologists in dealing with asthma. And actually our journey started about 50 years ago when asthma was nothing but smooth muscle disease. And at that time we were talking about bronchoconstriction and how we use treatment to relax the smooth muscle. It took us about 10 years to start talking about this airway hyperresponsiveness, that the asthmatic lungs are very angry. Whenever they are exposed to any irritant, if you like, they get very, very spastic. And again, it took us another 10 years to start realizing that this hyperactive airway is caused by inflammation. And it was late 70s, early 80s when we have documentation from bronchial biopsy on living patient that there is indeed an active inflammation in the airways. So at the moment we talk about bronchial asthma as a chronic inflammatory disease of the airway. This inflammation causes, if you like, the airway hyperresponsiveness that lead to the difficulty of really breathing, cough, and wheezing. With this kind of good understanding, we do have treatment that covers both aspects. We have those drugs that we call them controllers, and they are supposed to control the inflammation, while you have those drugs that only relieve symptoms by bronchodilate and improving. So we do have lots and lots of medication. But the big question is how good we are in controlling asthma patient. If we understand what's asthma, if we have drugs that work with this understanding of the basic physiology of asthma, are we good in controlling asthma? So the question is, have we resolved asthma? To answer this question, this was a European study called the INSPIRE in 8 European countries, asking patients on treatment if they are controlled or not. And as you can see that the vast majority of patients, about 70%, were either not controlled or only partially controlled. In a more global study called basically AIR study, Asthma Insight and Reality Studies in North America, Europe, and Asia Pacific showed that only 5% of asthmatic globally are well controlled. We have similar data from Saudi Arabia. This was a block survey when we introduced patients, about 1,500 patients, asking them 4 simple questions: daytime symptoms, night symptoms, activity limitation, and the use of rescue drug. And as you can see, 70 to 80% of the patients were not controlled. And finally, the part of the asthma ISAC study, phase 3 study in different countries in the Middle East, you can see that asthma is not controlled in the vast majority of country. And if you look at it, for example, Egypt, this was the prevalence of asthma, 14.7. Saudi Arabia, much higher. We have an allergic probably process in Saudi Arabia. So asthma is there. Asthma is not well controlled by our treatment modality. And the big question is why? What are the obstacles that prevent us from controlling asthma? If we know what's asthma, if you have a good drug, why we are unable to do that? And if you look at the literature, I think there are basically four main reasons. You have reasons for patients themselves, that the patient is unable or unwilling to use the drugs. You have the drug itself, you have the environmental factor, and you have some genetic component. Any of these can really influence the asthma control. But for the sake of this lecture, I'll emphasize mostly on the drugs. Assuming that we control everything, how can we further improve asthma control? But before addressing that point, let me just discuss with you, what do we mean by asthma control? And I think the GINA guidelines, which are the most respected international guidelines, talk about asthma control as two categories, if you like. You have this category that deal with the current symptoms. So I want the patient to have basically no symptoms during daytime, no symptoms during night times, not requiring Ventolin as a rescue treatment, and they have good exercise limitation. If everything is no, then the patient is well controlled. If you have one or two of those are not controlled, then this is partially controlled. More than two, this is poorly controlled asthma. But I think what's interesting that now the guidelines say this is not enough. The control of the current symptoms is not enough. What we need to do is we need to prevent further risk. And when we address that, they said there's three important things that we need to take care of. That is exacerbation, the prevention of airway remodeling, and keeping the dose of drugs to the lower dose to prevent side effects, especially when it comes to steroid, inhaled steroid or oral steroid. You would like to keep the doses to the lower possible dose in order to prevent the side effects. So controlling the current asthma is not enough. We need to control the current asthma and the future risk. And I think very interestingly, the guidelines give us some hint about some risk factor that make asthma not well controlled. Probably smoking asthmatic. We know that obese asthmatic, they have more lower airway diseases, and maybe sometimes they're difficult for the drug to reach the airways. Pregnancy, again, they might have that. We know that those who have asthma started late, or what we call late onset asthma, more likely to have small airway disease. Most of the data came from Japan. Maybe because Japanese people don't die. Usually they basically live forever. So they get really, really old. And sometimes asthma started in that basically category. But the important part is we need to control the disease with a lower dose of treatment. And let me share with you a case presentation to tell you how that can be put on a clinical context. So this is a 48-year-old woman, uncontrolled asthma. She was diagnosed 2 years ago, and since then she had frequent exacerbation because of her poor asthma control. Missed significant amount of work days, lifetime non-smoker. She's on fluticasone, solmetrol, seretide, 500/50 BID, and has been using a lot of Ventolin to rescue her symptoms, especially at night. Her asthma control test, based on the asthma control questionnaire test, is basically 19. Anything less than 20 is not adequately controlled. So this is patient on a good drug, LABA and inhaled steroid, which are the drug recommended by the guidelines. But you can tell that neither her daytime symptoms nor her future risk are well controlled. And this is her lung function. She's having significant airflow obstruction, significant reversibility. So I think the diagnosis of poorly controlled asthma is very clear in this situation. And this is kind of the treatment options. What do you think now the next step in management? Add Xolair, add tiotropium, check inhale technique, order sleep study, add the electrolyte modifying agent. Maybe because this is Boehringer lecture, you would choose number 2. But that's not the right, basically, answer. I think the right answer is always, let's go back to the basic. And let's be sure that the patient is using her Seretide and she knows how to use the discus device. If we assume that everything is controlled, then let's go back to this question. What is the best treatment option for this patient? This patient is not controlled on inhaled steroid and LABA. Where to go next? And this is our Saudi guideline. It's not yet published. It will be published in January. But we put down on step 4 that really tiotropium should be added if you are not controlled on low-dose inhaled steroid and LABA. But if you look at the studies that I'm going to share with you at the moment, I think you can really say that tiotropium might be considered earlier and can be considered later. Actually, we had a lot of debates in the Saudi guideline to say, should we put tiotropium here or here? We decided by voting at the end is to go for step 4, but I think there is reasonable data to show that maybe you should consider it even at step 3. And let me share this data with you. The first study I'm sharing with you is this phase 2 trial. Just to prove the concept of this, that patients who were not controlled on inhaled steroid LABA, basically on inhaled steroid, they were randomized to either solmeterol or tiotropium. So basically, I'm talking here about step 3 treatment. And in this phase 2 trial, that the patient were allowed to use solmeterol for a few weeks before the basically randomization, and they went into the randomization for 16 weeks. And what they found is that both solmeterol and tiotropium were quite effective. And tiotropium was not inferior to solmeterol when it's used as an add-on to the inhaled steroid. So this was the first proof in concept study. Until the famous New England Journal basically study came around looking for phase 3 trials in patients, again, who are not controlled on low-dose steroid. And in this paper, they were randomized into 3 arms. There were about 200 patients randomized into doubling the dose of steroid, adding LABA, or adding tiotropium. And this was non-inferiority study as well. So the statistic was adjusted not to superiority, to non-inferiority. And what they found that both adding tiotropium and adding solmeterol better than doubling the dose of the inhaled steroid. And when they look at it, tiotropium was certainly not inferior to solmeterol when add-on therapy. As a matter of fact, if you look at some of the parameters, it was a bit better, but they could not claim that because this was not our non-inferiority, it was not superiority study. But nevertheless, when you look at different aspects of asthma control regarding lung function or asthma control days, it was clear that tiotropium was as effective, at least as effective as solmeterol when it's added to inhaled steroid. What about step 4? That those patients who were not controlled on both inhaled steroid and LABA, can we add tiotropium to those patients? And again, this was a phase 2 trial trying to answer this question. Patients already on inhaled steroid LABA, like our patient that I showed you, who were not well controlled, what's going to happen if we add tiotropium? And in this paper, they absolutely did that by randomizing the patient into 3 arms: placebo, low-dose tiotropium respimat, 5 microgram, or 10 microgram. And this was, every 8 weeks, they cross over the patients between the placebo, low dose, and high dose. And this was basically a 24-week study. And again, the message was clear that adding tiotropium to patients who were not controlled on LABA inhaled steroid, those patients did very well by adding tiotropium. So that's, if you like, the step 4, where at least in our Saudi guideline, we're very sure that it should be there. But as I told you, we had some debate on step 3. And so looking at the lung function and the peak expiratory flow rate was significantly better by adding tiotropium to the regimen of inhaled steroid and LABA. So phase 3 trial took basically place to confirm this finding. This was a big study. Actually, these were 2 identical studies, but they published together, looking at the same thing, patients who were not controlled on LABA inhaled steroid. This was about 1,000 patients, 900 patients or so, randomized into either placebo or tiotropium. And they were basically followed for almost 1 year, 48 weeks. And in this paper, the primary endpoint was actually 3 components. Looking at the FEV1 changes within 3 hours after the 48 weeks. And what they found is that if that's the case, that was testing whether there is any tolerance in using tiotropium, improvement in lung function, and exacerbation. And when they look at the FEV1, clearly the message was clear that adding tiotropium to inhaled steroid LABA gave a lot of benefit. And there was significant improvement in the lung function that was maintained for the 48 weeks of the study, meaning that the tolerance was not an issue when you use tiotropium. This was unlike using LABA sometimes. And when they look at the exacerbation rate, which was the primary endpoint, they showed that by adding tiotropium, you decreases exacerbation by 20%. Furthermore, they look at worsening of asthma. So basically, this was a secondary endpoint that worsening of asthma meant in that paper not only exacerbation, but worsening in symptom scoring for 2 days, or worsening in lung function by more than 30%. And again, they found clearly that using tiotropium as an add-on to inhaled steroid LABA decreased the worsening of asthma and severe exacerbation by about 30 weeks. With all of these benefits, they looked at the side effect of the tiotropium when it's used as long-term. As I showed you, there was no signal to say there will be tolerance. There was no signal to show that tiotropium used for long-term in asthmatic patient will cause any significant side effect. And as you look at the side effect between tiotropium group was 8%, 8.1, and the placebo was 8.8. So it was very close to the placebo. There was no major signal of side effect of using tiotropium long-term in those patients. And if you look at different, basically specific side effects, nothing was alarming. I'm sure you know about the concern initially that tiotropium respimat can be associated with increased cardiac mortality or cardiac risk. But I think the New England Journal study specifically directed for this point really put that issue at rest. And there was, again, no concern for any side effect. So the conclusion was, from these papers, that by adding tiotropium to inhaled steroid LABA, you do improve lung function, you do improve symptoms, you do improve exacerbation, and finally, the composite endpoint of really all of this as the worsening asthma significantly in patients who are not controlled in inhaled steroid and LABA. So, ladies and gentlemen, let me conclude here by telling you that I think now all of us here, we agree that asthma is an inflammatory disease, and there is more than one factor behind the poor asthma control in our asthmatic patient, whether this is related to the patient himself, to the medication they are using, environmental factor, or genetics. We now realize that whenever we would like to control asthma, we have to control both the current symptoms, but also to modify and reduce the future risk of exacerbation and the side effects of the medication. The guidelines are still clearly mentioning that inhaled steroid and LABA is the preferred aspect of treatment whenever the patient is not controlled on inhaled steroid, and this is all guidelines having this statement very, very clear. But as I showed you, we know as a reality that the vast majority of our asthmatic patients are not well controlled for a reason or another. And I hope that I showed you evidence that tiotropium is a new hope for our asthmatic patient. And I think personally, it is a drug that can be used early as step 3, at least in those patients who might have some problem with LABA because of cardiac toxicity or something. So it can be used as a replacement for LABA, and the data has shown that it is not inferior to LABA, but also it can be used as an add-on treatment to inhaled steroid LABA in those who are not controlled on that combination. Thank you very much for your attention.
Thank you very much, Majdi, for your excellent expose as usual, for giving new hope for the asthmatic patient. You gave this morning hope, and always giving hope for the patient's pulmonary hypertension, and now you are giving to another patient, the asthmatic patient. We are beyond the schedule, but if only one short question with one short answer to Majdi. Please, Dr. Abmina.
Can you use the microphone, Dr. Larson?
Mechanism of action in asthma, is it similar or different from its role in COPD? And in comparison with the fast acting glycopyrronium, should we use the other drug? It gives more or more rapid onset of action in asthma, and the role of thermoplasty.
So short answer, as Professor Al-Khattab said, for the first one, do they work as COPD? Very short is probably yes. It's used on basically anticholinergic pathway, which is different from LABA pathway. So it has nothing to do with beta receptors. It works more on the cholinergic side. So at least our understanding that it works on that pathway. The question whether it has any synergistic anti-inflammatory effect with inhaled steroid like LABA does in translocating the steroid receptor, we don't know for sure, but there was some study showing that some stabilization of the eosinophilic cells and mast cells by using tiotropium. But so far we're not claiming that it is an anti-inflammatory drug. It is as LABA, it is a bronchodilator. Now the second question was about the short-acting, long-acting tiotropium that might come to the market. Now, none of these drugs are supposed to be used as a rescue drug. So I think that, for example, if you are not using these drugs as a rescue drug, then it's very difficult to say whether there is any advantage of that. We're still using Ventolin or SAB as the rescue drug. So really, for the drug to work in 5 minutes or 15 minutes, that doesn't make much difference. When you come to the long-term control of asthma, and this is why, for example, when we use formoterol and salmeterol, on the overlong control, probably they are comparable. The only difference will be if you're going to use this drug as the rescue drug, then that's a different story. We don't have data to compare the different LAMA at the moment and whether one of them is better than another. So we don't have that information. You would assume that because they are LAMA, they might work in the similar direction and they will give you the similar effect, but that's only an assumption. There is nothing to confirm that because the data is not there. thermoplasty.
Thank you so
I'm not
much.
a broncologist. The bronchologists are sitting on that table.
Quite agree. Thank you so much, Majdi.
Thank you.
And now it's the time for the last session for today. This is Novartis Symposium. May I call the chairpersons, Professor Tariq Safwat, Professor Ashraf Hatem, and Professor Gamal Agami.